Dental hygiene students, today we will be reviewing Chapter 19, Periodontal Disease Development. Your risk assessment tools are used to identify the level of development and progression of periodontal disease, and it's important to individualize the treatment that you're recommending to the patient. It can improve patient outcomes and reduce their overall cost of treatment. Examples of some of these risk factors include your periodontal risk assessment and periodontal risk calculator. Periodontal risk calculator uses known modifiable factors that the patient can change in order to predict the risk of periodontal disease and periodontal disease progression. This specific risk assessment has shown a high level of accuracy in studies. Risk assessment is based on tooth loss, genetics, systemic conditions, periodontal status, and age. It predicts the progression of periodontal disease, and here's the website for it. The picture is right off the website, so that you can see this is Chatty Cathy. This is this year, right, 2023. She's 56 years old. She's got 28 teeth, and that includes implants. The number of sites per tooth is 6, right? Because when we probe, we check 6 sites. And then you put the number of bleeding on probing sites, and that was only 12. So it calculated that, 28 teeth, 6 sites, it was 128 bleeding on probing sites, and 12 of those were bleeding. Number of sites with greater than 5 millimeter pockets, she has 3 sites, and she's got 1 missing teeth, and her radiographic bone loss is about 20%. She does have systemic issues. She has hypothyroidism, and she is a non-smoker. And so what this does is it calculates everything for us based on that. So you can see here that she's got a periodontal risk. She's got a medium periodontal risk, and recommendation is consider attention on modifiable factors. Okay, now she wasn't a smoker, but maybe she's got other factors there like diet that she can possibly change. Etiology of periodontal disease is dependent on the microorganisms that are present, and the complexity and diversity of the microorganism change, so does the progression of the periodontal disease. So as those microorganisms begin to become anaerobic, that tissue also begins to shift over, and it goes from healthy to diseased. Okay? So the microbiome of healthy tissue is not the same as it is in gingivitis and periodontitis. The type of organisms will shift from gram-positive aerobic to gram-negative anaerobic species as that disease progresses. So type of organisms in the oral cavity include your P. gingivalis and your Tetranella forsythia, as well as your Treptonoma denticola and your Fredibacteremia species. These can be viewed under a microscope in the office, and they can be measured using oral bacterial testing such as oral DNA. So P. gingivalis is associated with cardiovascular disease and rheumatoid arthritis. And if you look at the picture here, you can see this is from Oral DNA Labs. You can go right on their website. I put it in the notes, and you can look into it. But do you see these darker bars here? That lets you know how much of that specific bacteria is in that patient's oral cavity. And so this is what's considered the threshold, where that dark black band is. That's the threshold. Anything above that can be really dangerous to the patient. And they actually tell you the type of bacteria in there. They tell you if it's a high-risk bacteria, a moderate-risk bacteria, or a low risk. And then down here in this chart, it tells you what that bacteria is associated with. So let's take P. gingivalis. That's going to be this PG, and it's associated with gum disease, but it's also associated with preterm birth, and it's associated with metabolic health. It can worsen diabetes. It's associated with dementia and brain health. It's associated with musculoskeletal health and changes with chronic joint diseases like rheumatoid arthritis. It's also associated with cardiovascular health and with cancer. So gum disease is a cause of ongoing inflammation, which can promote the advancing growth of tumors. Oral bacteria under a phase microscope. Some offices do currently have these, and so what you do is you use your instrument, you grab some of that bacterial plaque, and you can place it on the slide, and you put it underneath the microscope, and it actually, patient can see it on the computer screen, and they can see all the bacteria swimming in that bacterial plaque. Identifying risk factors can give you insight into the assessment and help you provide a great care plan that's patient-centered. Keep in mind that microorganisms do not affect everyone the same way, which means that periodontal disease severity and progression is going to be dependent on the host response. You're going to evaluate the modifiable risk factors, which include tobacco, diabetes, metabolic syndrome, obesity, diet, and excessive alcohol intake. Most of these factors can be changed by the patient. However, it's going to require collaboration with their medical providers for treatment. Smoking cessation increases the risk of periodontal disease by 85%. Diabetes and periodontal disease have a bi-directional relationship, meaning that poor control of the blood glucose results in poor outcomes for treatment, and it decreases their wound healing. Metabolic syndromes include hypertension, excess abdominal fat, and high cholesterol. Odds of having periodontal disease with obese is doubled. Diet high in carbs can increase the risk due to initiation of inflammatory state, and deficiencies in vitamins can impact healing. Stress can increase a patient's risk, and medications can cause gingival enlargement, which will cause dental biofilm retention. And as we know, biofilm is the primary etiologic cause of periodontal disease progression. This is the attachment loss seen on a smoker. You can see that they have lost that interdental papilla. Those embrasure spaces are open, so they do have some visible bone loss. They have some areas of recession. So all of these areas of recession are going to be at higher risk for developing carious lesion. This one actually looks like there's already one there. But they're just going to be at higher risk. Now, with smokers, you might not notice as much bleeding as you would with a non-smoker, but the periodontal disease is still present. Here is a picture of the oral cavity of a person who was taking nifedipine, which is a calcium channel blocker that's used for treatment of angina and ventricular arrhythmias. You can see that gingival enlargement, but this is caused by medication. So it's medication-induced gingival hyperplasia, which also causes biofilm retention and makes it harder for the patient to keep this clean. Risk factors for periodontal disease. You have non-modifiable risk factors, which include genetic predisposition. Genetic testing can help determine risk related to genetic factors. The host response is the person's immune system and how they respond to the bacteria. A person who's immunocompromised or has a chronic disease will result in higher prevalence and severity of periodontal disease. Osteoporosis, because there is an association between periodontal disease, a person with osteoporosis has increased risk of greater millimeters of clinical attachment loss. Age is factored in to take into consideration more severe periodontal disease at an earlier age. Risk factors include retentive areas, iatrogenic factors, and dental factors. So retentive areas are going to be areas that tend to accumulate more plaque or hold and retain that dental plaque and biofilm. Iatrogenic factors are going to be things that we as dental professionals create, like maybe it's the dentist put a restoration in there that has an overhang and now is creating a plaque trap. Then you have dental factors, which also can contribute to that, such as oral habits, which can contribute to retention, such as lack of brushing and flossing or poor home care. Factors are going to include tooth surface irregularities, such as pits and fissures. Tooth contours include an altered shape that can interfere with oral self-cleansing. Malocclusion can make areas more difficult or more prone to collect biofilm. Things such as an open bite can affect the natural cleansing as well. Food impaction and effective contact areas can increase biofilm retention. Dental appliances and prosthesis can cause retentive areas, especially around the clasp. Tooth position can cause food impaction. This includes overhanging restorations, drifting of teeth or tipping can cause retention of debris right in between those teeth, especially if you have mesial drifting, you're going to get some food impaction in this area, and it's going to make it harder to maintain it and keep it clean. If you have an open contact, that's also going to retain plaque and biofilm more easily, and it's going to be a little bit harder to clean, which is then going to eventually possibly cause some bone loss. Restorations. So on this radiograph, you can see the overhanging restoration on tooth number 30 on that distal. Retention of bacteria can occur there, which can contribute to recurrent decay and periodontal disease. Your open bite can make it harder for your mouth to do its natural cleansing process. It can also cause dehydration of the tissues. And that dehydration of the tissues can cause the gingival margin here, especially on the anteriors, to get very inflamed, which again is going to cause plaque and biofilm retention. Orthodontic appliances are going to tend to hold a lot more plaque and bacteria, and it's going to be harder for the patient to thoroughly clean the areas around the brackets and the wires and the ties. Gingival factors associated with periodontal disease include gingival recession, inflammation, or operculum, which can all cause retentive areas for biofilm. Deviation of the shape of the gingiva, as well as dehydration of the oral tissues due to mouth breathing, can increase that biofilm retention, making the oral cavity a perfect environment for bacterial growth and proliferation. Here is an operculum. It's over a partially erupted third molar, and this can cause tissue inflammation, which leads to biofilm retention, and it makes it more difficult to clean. This is also going to be a caries risk because there's going to be so much food and biofilm stuck underneath that pocket that it's very difficult for the patient to clean. And even if they can clean it, they typically won't because the tissue is very sensitive when you try to move it. Other factors include lack or neglect of personal oral self-care, along with lack of access to oral health care aids that are needed for adequate dental biofilm removal. So maybe the patient would benefit more from a water pick than they would from floss, but they just can't afford it or just don't have access to one, right? Lack of awareness of the need for biofilm removal and its effect on the oral cavity and systemically. Diet plays a big part on it. Soft foods that are less nutritious tend to be more retentive and higher in carbs. Pathogenesis of periodontal disease, acute inflammatory response. So pathogenesis refers to the process of how the disease develops and progresses. The inflammatory process is very complex and it's influenced by the patient as well as the environmental factors, and it's impacted by the individual's host response to that bacteria. Acute inflammatory response will begin the process of lesion development. So the initial lesion will occur within 2 to 4 days, and the migration and infiltration of white blood cells and neutrophils into the junctional epithelium of the gingival curvicular fluid. There's no clinical evidence of change in the earliest phase, and the early lesion, after about 3 to 5 days, your dental biofilm becomes older and thicker. There's more infiltration of macrophages and T cells and neutrophils, and there's a breakdown of collagen fiber, and clinically you'll start to see early signs of gingivitis. Gingivitis is reversible with biofilm control. The established lesion is about 2 to 3 weeks, and there's migration of B lymphocytes and plasma cells in the connective tissue. Collagen destruction continues, and clinical appearance is inflammation with marginal redness on bleeding on probing. The gingiva becomes spongy and you lose that stippling. Your advanced lesion, there's 2 hallmarks of advanced lesion, and that's alveolar bone resorption and collagen breakdown. Characteristics of the advanced lesion are pocket formation and bleeding and bone loss. The presence or absence of infection will distinguish a pocket from a sulcus, and the level of attachment on the tooth distinguishes the gingival pocket from a periodontal pocket. The pocket has an inner wall and an outer wall, and they meet at the base of that junctional epithelium or pocket. That base is the coronal margin of the attached periodontal tissues and the border of the junctional epithelium. Substances that are found in the pocket include gingival crevicular fluid and desquigmented epithelial cells. So a gingival pocket or a pseudopocket, the definition is a pocket formed by gingival enlargement without apical migration of that junctional epithelium, meaning the margin of the gingiva has moved up towards the incisal or occlusal edge, and they are suprabony, meaning it is above the bone, with no bone loss. Periodontal pocket definition is the pocket is formed as a result of disease or degeneration which causes apical migration of the junctional epithelium along the cementum. The tooth wall of the pocket is cementum. Pockets can be suprabony and intrabony or infrabony, which means within the bone. Suprabony irregularities in the pockets can be detected by drying the surface and observing it under the light. Detection of subgingival irregularities on the tooth surface will be dependent on tactile and auditory sensitivity that's transmitted from your explorer and probe. Tooth surface irregularities include enamel surface irregularities and root surface irregularities. Those can include cracks, overhanging restorations, hypoplasia, calculus, and carious lesions. Types of suprabony periodontal pockets are going to be normal, gingival, periodontal. Types of intrabony pockets will be seen in periodontal disease only. Notice the bone loss on the pictures marked periodontal. They are intrabony. Notice the bone. This one has a lot more bone destruction than this one, but they both have bone loss. Your gingival or normal periodontal pockets have perfectly healthy bone. Classification of furcations. Furcation involvement means that the clinical attachment level and the bone level have extended into the furcation area between the roots of multi-rooted teeth. Glickman for furcation grades were previously discussed in detail in Chapter 20. You can see the different furcation grades in this picture. The way you detect it is going to be with your neighbor's probe. If you look at type 1 furcation, you can see that the gingival margin, which is this blue line, is at the CEJ. However, the bone loss, which is this red line, is below the CEJ, and your instrument can detect the indentation between the roots. With type 2, your neighbor's probe can go in between the roots but not through it. With type 3, your instrument can go through or right directly in between those roots. With type 4, there is clinical exposure, so your gingival margin, this tooth now has recession, and you can clinically see between the roots or see the roots clinically with your eyes. Okay, before you touch it with the neighbor's probe, you can see where these two roots meet. Okay. The blue line depicts the gingival margin and the red line depicts the bone. You will have to draw these lines on your paper charts. Furcations can be very difficult to debride, which can make it difficult to manage and stop the progression of periodontal disease, which can increase the risk for tooth loss. If we're not able to completely clean it or clean it to completion, we're going to leave things like calculus behind, which is going to be hard to create the right environment where you've removed all that bacteria which will then create an increased risk of losing the tooth, right? Because you aren't able to control the disease and the biofilm bacteria in the pocket. Okay, so clinical observations, the furcation can be covered by the gingiva. Similar to the picture that I showed you earlier, where the gingiva was at the gingival margin, but the bone loss was below the mucogingival junction. So the furcation, sometimes are covered by the gingiva. They can only be seen directly if there's recession and bone loss. Otherwise, you're going to have to see them radiographically. So here they've placed a triangle there so you can see where that furcation is, but if you view the other side of this x-ray, it's the same x-ray. You can see the roots here where that indentation of the furcation is. A pocket that extends to or beyond the mucogingival junction, which is this red line, into the alveolar mucosa is said to have mucogingival involvement, meaning there is no attached gingiva in that area. The probe, or when probed, it goes into the alveolar mucosa. The picture shows what is known as a mucogingival defect. It shows a very narrow zone of keratinized gingiva on tooth number 24. Okay, notice the width here of that attached gingiva versus the width on tooth number 24. So a mucogingival defect is usually 1 millimeter or less of attached gingiva. So if the probe depth reached or exceeded the mucogingival junction, there would be no attached gingiva and a mucogingival defect would be present. Evidence suggests 1 to 2 millimeters of attached gingiva is desirable. The 2017 World Workshop on the Classification of Periodontal and Peri-implant Diseases in Conditions proposed a new classification for mucogingival conditions based on treatment and potential root coverage, and it includes the following components: your periodontal biotype, gingival recession, which is related to the interdental clinical attachment loss, the lack of keratinized gingiva, the frenum position, gingival excess, so excess gingiva, right? And then your abnormal color. Recognition of normal and abnormal depends on a systemic step-by-step examination. A comprehensive periodontal exam is used to gather information and identify the signs and symptoms. Infections are confined to the gingiva, and periodontal infections include all parts of the periodontium, including bone and cementum. And remember that gingivitis is reversible. Signs and symptoms. So the patient may not feel any pain at all, or they might bleed. They might notice bleeding when they brush or floss, or they might notice spontaneous bleeding. They could also report sensitivity to hot and cold, food retention, bad breath, chronic bad taste, and they may notice or report that their teeth feel loose. Changes in tissue. So causes of tissue changes are due to the inflammatory response as well as the breakdown of that inner cellular substance and increased permeability of the capillaries. Changes produced on the tissue include the color, the size, the shape, and the consistency. Signs that are associated with periodontal health on an intact periodontium, as well as a reduced periodontium that is stable, includes less than 10% of bleeding sites and probing depths that are below 3 millimeters. Additional signs include control of modifying factors such as diabetes and cessation of smoking, which would include no probing depths above 4 millimeters that bleed on probing. Patient of gingivitis can be plaque-induced and non-plaque-induced. Clinical signs include blunting papilla, less than 10% of bleeding on probing, and less than or equal to 3 millimeters of probing depths. Local risk factors include dental biofilm and xerostomia. Other factors include leukemia and hyperglycemia, as well as smoking and elevated sex hormones. Dental plaque-induced gingivitis is due to biofilm, and the inflammation is reversible. So dental plaque biofilm-induced gingivitis factors include metabolic factors, smoking, malnutrition, drug-induced xerostomia like nifedipine, and elevated sex hormones, which include your puberty, your menstruation, pregnancy, and oral contraceptives. Drugs can cause gingival enlargement, which can be most commonly seen early in the anterior areas on the papilla. Some medications that cause this will be your nifedipine, your calcium channel blockers, your anti-epileptic drugs like Dilatin, and your immunosuppressants like cyclosporin, and high doses of oral contraceptives. This is a picture of the oral cavity of a person who is taking nifedipine, which is a calcium channel blocker that's used for the treatment of angina and ventricular arrhythmias. You can see that tissue is really inflamed, which will make it difficult to thoroughly clean those periodontal pockets. And tissue like this is normally fairly firm. Non-dental plaque-induced gingivitis can be due to several factors, including genetic causes of gingivitis, even though they're rare, but are an example of hereditary gingival fibromastosis. Necrotizing gingivitis is due to poor oral hygiene and stress, as well as a compromised immune system. Infections such as gonorrhea and syphilis can also cause non-plaque-induced gingivitis. Autoimmune diseases such as lupus have a reactive processes due to response to local irritants or trauma, such as pyogenic granuloma, which is seen during pregnancy. Premalignant lesions such as leukoplakia and malignant conditions such as lymphoma. Vitamin deficiencies like scurvy due to lack of vitamin C, and traumatic lesions like self-injury due to habits like nail biting. Gingival pigmentation due to smoking. Those are all causes of non-dental plaque-induced gingivitis. Necrotizing periodontal disease begins as an acute condition with rapid tissue destruction. It's characterized by pain and ulceration of the gingival margin with punched out papilla. Your classification of periodontitis is going to include certain criteria. One of those is going to be the severity. So you have your interdental clinical attachment level. You have mild, moderate, and severe. So your slight to mild is 1 to 2 millimeters, your moderate is 3 to 4, and your severe is greater than 5. Your radiographic bone loss, you have less than 15%, 15 to 33%, and beyond that middle third, which would be your advanced. Tooth loss, you can have none, 1 to 4, and 5 plus. Complexity is going to be based on the pocket depth, the type of radiographic bone loss, if there's any furcations present, and if there's any occlusal issues present. So pocket depths less than 4 millimeters, 5 millimeters plus, or 6 plus millimeters. Then you have your extent. Is it localized, which would be less than 30% of the oral cavity or less than 30%? And then you have your generalized, which is greater than 30% of the oral cavity. And then you have your molar incisor pattern, which tends to progress faster and be more aggressive. These terms may also be used when describing the extent and distribution of gingival inflammation. That includes marginal, papillary, and diffuse. Marginal means the change is confined to the free or marginal gingiva. It could be localized or generalized. Papillary is a change involving a papilla, but not the rest of the free gingiva around a tooth, and that change may be localized or generalized. Then you have a diffuse or spread out, and it affects the gingival margin, the attached gingiva, and the interdental papilla, and it may extend into the alveolar mucosa. This is a flowchart that we use to help assess and determine your patient's periodontal status. It includes the severity and the complexity of the different stages that are associated with periodontal disease progression. This is also in our policy manual. So if we take a look at this, you can see the severity. It's asking about your interdental clinical attachment loss at the site of the greatest loss. Okay, 1 to 2 is stage 1, 3 to 4 is stage 2, and greater or 5 or greater is going to be your stage 3 or stage 4. Your radiographic bone loss, is it at the coronal third, or middle third and beyond? Tooth loss, is there any, no tooth loss, 4 teeth or less, or more than 5 plus? Complexity, is it localized, is it generalized? Okay. Your maximum probing depth is for 4 millimeters or less, mostly horizontal. Your maximum probing depth for stage 2 is 5 or greater, mostly horizontal bone loss. Here you have your grading. So you have your primary criteria, which is indirect evidence of progression or direct evidence of progression. Then you have your longitudinal data, your radiographic bone loss or clinical attachment level. Clinical attachment loss. You have your percent of bone loss divided by the age. That'll help you determine the severity of it, especially if the patient is young. This might be an easy way to do it for someone who's young. Your grade modifiers, do they smoke? Are they diabetic? Do they have high severity or high sensitivity? Grade A is a slow progression. Grade B is moderate rate progression. Now, if it's a new patient and this is the first time you see them, they're an automatic B. And then you either go up or down or stay where you're at, depending on how they look the next time you see them. So step 1 is the initial assessment, which includes patient history, risk assessment, clinical examination, radiographs, and periodontal exam. Step 2 is establish the stage by identifying areas of interdental clinical attachment loss. Evaluate the extent and the type of radiographic bone loss. Step 3, establish grade modifiers by evaluating the medical history and the risk factors, as well as assessing the progression of radiographic bone loss by dividing the radiographic bone loss percentage by the patient's age. So if Tom had 50% bone loss and he was 25, okay? So if you're dividing the bone loss percent, which would be 50, by his age, which let's say he's 25, that's 50%, right? I'm not going crazy. That's 50%. So he's going to be more of a grade, probably C, than a B. It's going to be more severe. And if I'm doing the math backwards, it equals to 2. All right, your acute periodontal lesions are classified according to etiology, which include acute exacerbation due to untreated periodontitis or after scaling. Periodontal abscesses and non-periodontitis patients include impaction of popcorn hole, nail biting, gingival overgrowth, and root fracture. Necrotizing periodontal disease is typically acute but can be chronically compromised patients, like patients with HIV and AIDS or due to malnutrition. Endoperiodontal lesions with root damage includes root fractures. Endoperiodontal lesions without root damage is beyond the scope of practice for us, so we do not touch those. Documentation is going to include a complete medical history and vital signs, as well as patient chief complaint, consultation with the patient's primary care provider if necessary, and it's going to include risk assessments such as caries risk and Mallampati score. A comprehensive periodontal exam and periodontal classification, treatment plan, consent forms must be signed by the patient before you put that instrument or scaler in their mouth. Before you begin treatment, that patient needs to sign the consent form giving you permission to proceed with whatever treatment you recommended. Teach the patient will include educating the patient about the connection between periodontal disease and systemic disease and related to their medical history. You're going to describe the risk factors for the patient and discuss any modifiable risk factors that they can be working on. You're going to explain healthy versus disease and clarify the need for adequate self-care and continuing care to help prevent or manage the infection. This is your clinical practice of dental hygienist, 14th edition, page 343 through 363. All other references are cited in the designated slide.